High school class. Today we are going to talk about the insulin regimes, types, their benefits, and the challenges. And now, first we have to discuss about the learning objectives, what we are going to talk today, and that is to recognize the common challenges encountered during insulin initiation, and then to understand the different regimes, types, benefits, and challenges. So first, let me talk about how the insulin secretion occurs. Now, in a normal person, as you know, the insulin secretion occurs at the basal level, and then with each meal, there is a rise in insulin secretion. So conventionally, we take a breakfast and blood glucose level tends to go up, and then we take the lunch, then blood sugar again tends to go up, and then we take the dinner, and then blood sugar again tends to go up. With each rise in insulin glucose level in the blood, there is a rise in the insulin secretion to maintain a normal glucose homeostasis in the body. So therefore, if we look into the insulin secretory pattern of normal pancreas, it is basically of two different types. One is continuous low level secretion between meals and throughout the night, and we call it basal insulin secretion. And second, there is a stimulated insulin secretion following the meals, breakfast, lunch, and dinner, and we call it as prandial insulin secretion. So therefore, insulin secretion are of two types, basal and prandial, and therefore, when we try to manage our type 2 diabetic subjects, we have to understand that there are two different ways we can actually give insulin, either in a basal or with prandial. Now coming to little bit of insulin kinetics, which all of us should understand, that whenever we give an insulin injection, they form a depot inside the tissue. And over a period of time, it enters into the circulation and exerts its action on the target cell. So the biological action of the insulin after the injection is little bit delayed because it has to go through the process of absorption from the subcutaneous tissue into the circulation, and then it acts on the target cell. So when we inject an insulin, the regular insulin or normal insulin, then it takes roughly around 20 to 40 minutes time to act. And that is why the regular insulin is injected 20 to 30 minutes before the meal. Now, where the insulin is degraded, most of the insulin is degraded at the level of the liver, and the second most organ is the kidney. So therefore, we have to understand that if a patient has got a chronic liver disease, the insulin degradation is low, and therefore a patient who have chronic liver disease become very sensitive to the insulin therapy and may develop frequent episodes of hypoglycemia with the same amount of insulin. And similarly, as you can see that the around 10 to 20% of the insulin is again degraded by the kidney. So in patients with chronic kidney disease, again, the patient become very sensitive to insulin and the possibility of hypoglycemia goes up. So this is the insulin kinetics which I have talked, and when we give an insulin injection, they actually form hexamer in the subcutaneous tissue. So the 6 insulin molecule form the hexamer, and after the hexamer formation, they undergo dissolution or dissociation, and it becomes dimer, and after the dimer it becomes monomer, and in the monomeric form, they are absorbed and they exert their effect on the target cell. So therefore, the whole process takes some time, as I've told you, takes roughly around 20 to 40 minutes time or 15 to 45 minutes time, whatever you say. And we actually advise the patient to take the regular insulin, say 20 to 30 minutes before taking the meal. It is because of the fact that insulin takes time to exert its action. So now if we look into the different types of insulin, as I have already discussed, we mostly use this regular insulin or short-acting insulin. It is the earliest insulin which has been discovered. So this insulin, as the name signifies, is a regular insulin or the natural insulin, and they are the short-acting insulin. And their onset of action, as I've told you, roughly around 30 minutes, and their peak goes 2 to 3 hours, and they have a short duration of action, as the name signifies, the short duration of action, so 3 to 6 hours. So you can see that if we want to manage diabetic subjects with this insulin, quite naturally, you have to give 3 shots before breakfast, before lunch, before dinner, because they have a very short uh, period of action. The duration of action is short. On the other hand, this insulin will not be effective in maintaining or controlling the fasting plasma glucose. To control the fasting plasma glucose, if we give an insulin at the bedtime, it should be effective for a period of at least 10 hours or 8 hours. So the people tried to develop a better insulin which has got a longer duration of action. So then we have this intermediate acting insulin, or we traditionally call it as NPH insulin. So when this NPH insulin was discovered, then we found that this insulin has got a duration of action roughly around 12 hours. And therefore, if we give this insulin at bedtime, it will effectively control the fasting plasma glucose. And if we have to control the blood sugar throughout the day, you can give 2 shots, one in the morning, another in the evening, to cover the whole 24 hours, because the duration of action is roughly around 12 to 14 hours. After this discovery of this insulin, we have found that for this intermediate acting insulin, we have to give 2 shots in a day to provide a basal insulin support. And then also this insulin has got a peak action between 4 to 6 hours, and the possibility of hypo is high. So the people started developing some insulin, which we call long-acting insulin, which has got usually don't have a peak action. There's a flat insulin. The duration of action is 24 hours or longer. And under this heading, we have glargine, detimir, degludec, and glargine U300. So these are the few varieties of insulin we have as a long-acting insulin. Each one of them is good, but there is subtle difference between these 4 varieties. So it depends on the patient condition and affordability on which we prescribe the different types of insulin. Now, apart from this, if you look into the regular insulin, though its onset of action is 30 minutes from the after giving the injection, they are also associated with hypoglycemia, because their action, duration of action is quite longer than what we expect when we have the mealtime insulin secretion by a normal pancreas. So therefore, as the possibility of hypoglycemia goes up because of the slightly longer duration than expected when we give regular insulin, then the people thought, let us develop something more close to the physiologic pattern of insulin secretion. And then the rapid acting insulins were developed, which onset is very short, peak action is 1 hour, and duration of action is shorter, and therefore the possibility of hypoglycemia is low. And in this heading, we have 3 different varieties: insulin glulysin, lispro, and insulin aspart. Now, there is hardly any difference between these three, even if you look into the head-to-head studies, though there is subtle difference, but not much as far as the clinical practice is concerned. So anyone you can use in your clinical practice. It hardly matters whether using you this one, or that one. Now coming to the normal insulin structure, which all of you are aware is of roughly around 51 amino acids, and they have a two chain. One is A chain, another is B chain, and these two chains are actually linked with each other with two disulfide bond. So there's two bond here. Now, whatever the newer varieties of insulin discovered or developed, they actually uh, had some changes in the insulin structure so that they can change the pharmacokinetic property of the insulin. As for example, this aspart, lispro, and lulacin are associated with some change in the amino acid sequence in the insulin chain in the insulin B chain, and on the basis of change in the amino acid, the three different varieties of insulin was developed. And as I've told you, they has got subtle advantages over and above the conventional regular insulins. Now, when we give a rapid acting insulin analogs compared to regular insulin, as I've told you, that the regular insulin actually has got a longer duration of action than expected, and it has got a slightly less peak compared to the physiological pattern of insulin secretion. So it's slightly slower in onset and slightly slower to disappear from the blood, and therefore compared to normal insulin secretion pattern, therefore there is a possibility of hypoglycemia when you give regular insulin. And second point, as because you have to wait for 20 to 30 minutes or 40 minutes before the intake of meal, so it actually have some impact as far as the quality of life of the patient is controlled. But when you give this rapid acting insulin analogs, you can inject the insulin just before the meal, maybe 5 minutes, maybe lesser than that. And if you by chancely missed the insulin injection, you can give it even after meal. It hardly matters whether if you have given the injection just before meal or just after meal. So that is an important advantage of the rapid acting insulin analogs. The patient don't have to wait, and therefore it has got a better acceptability as far as the patients are concerned. And second point is the possibility of developing hypoglycemia will be low, especially when you give this insulin before the before the dinner. Then the possibility of nocturnal hypoglycemia will be less compared to the regular insulin. And third, as because its peak goes up, so compared to the regular insulin, so it will have a better prandial correction uh, than the your regular insulin. So these are the few advantages of rapid acting insulin analogs compared to your regular insulin. Coming to long acting insulin analogs, as I've told you, that all the insulins, all the designer insulin or modern insulin are basically modified human insulin molecule uh, with respect to their amino acid sequence, and also some of the insulin say deglutic associated with some addition of fatty acid side chain. So so these are there are the glargine, which is basically a modification into the A chain, the detamere, which is basically an attachment of fatty acid, and you have degludec, which is also an attachment of fatty acid. So there is change in the amino acid sequence with the glargine. So you don't have to remember all these issues, but you have to remember that all the designer insulins are actually some kind of modification into the normal human insulin chain. Now coming to the pharmacodynamic profile of the long-acting insulin, compared to intermediate-acting insulin or NPH, you can see NPH insulin is basically have got a much shorter duration of action, roughly, as I've told you, around 12 hours to 14 hours at best. So they have got a very short duration of action, and to get a control over 24 hours, you have to inject this insulin twice in a day. On the other hand, if you look into the tetimate, its duration of action is much better compared to the NPH. But as my personal experience goes, that even though duration of action is slightly better than NPH, in many situations, we have to give tetimate twice in a day. And therefore, it is not actually a very good long-acting insulin. On the other hand, if you look into the glargine, which is a gold standard of basal insulin therapy, you can see that giving an glargine actually have a very flat profile, and their duration of action is almost 24 hours. So therefore, if you ask me between these three insulin, then I'll consider the glargine will be the best compared to the NPH and compared to the tetimate. So if we look into the different types of insulin, as I have discussed, I've told you we have the regular insulin or short-acting insulin. And these are the brand name I have already given to you. So with this brand name, they are available into the market. All of them are same. They are regular insulin. Most of the insulin has got this R mark uh, with the trade name. So therefore, you can easily understand that they are basically the regular insulin. As I've told you, they take time to act, and therefore you have to inject it, say half an hour before the meal. They have a big action, and they have a slightly longer duration of action, and therefore expected to produce some kind of hypoglycemia, especially when you give it before breakfast. Sometimes we find that this insulin uh, is associated with pre-lunch hypoglycemia or mid-morning hypoglycemia. On the other hand, the rapid-acting insulin, these are all designer insulin, all three, as I've told you, that there is hardly any difference between these three, except that they are developed by three different pharma houses. Their onset of action is almost similar, peak action is similar, and, and duration of action is much shorter compared to the regular insulin. And you can use both these two varieties of insulin as I've told you, as a mealtime insulin, or we sometimes call bolus insulin. So this short-acting insulin and rapid-acting insulin are used as a mealtime insulin or as a bolus insulin. On the other hand, the intermediate-acting insulin or NPH, I've given you these trade names. Their duration of action is 24 almost say 12 to 14 hours, not 24 hours, 12 to 14 hours. And therefore, you need to give this insulin twice in a day. And as I've told you, that they are often associated with hypoglycemic episode because the fact they have some peak action. Coming to the long-acting insulin preparations, now we have the glargine, we have tetimate, and we have insulin degludec. So these three insulins, if we look into it, as I've told you, the tetimate don't actually have not duration of action up to 24 hours, and therefore often we have to give insulin twice in a day. On the other hand, glargine, on the other hand, have a duration of action almost 24 hours, no peak time, and is a very good insulin as far as the long-acting insulin is concerned. Now, insulin degludec, on the other hand, no peak time, and insulin is delivered at a steady state, and it has got a duration of action of 42 hours, and therefore it is a very good insulin as far as the basal insulin is concerned. So all three insulins are actually used as a basal insulin. There is a kind of sound, Dipankar. Can you
Yes, sir.
just
I can also.
can you just
But
check
is
the someone's mic is actually working?
so everybody is on mute, sir. I can see. Except you, everybody is mute.
This sound was not there.
Then also, एबार ठीक है sir? You're on mute. Sir, you're on mute, sir. No, we can't hear, sir. You're on mute.
But there is someone's mic is, I think, working.
Sir, we cannot hear, sir. We can't hear you.
Hello.
I think, sir, the headphone is troubling, sir. Your headphone is troubling, sir. It's not. We can't hear you.
Hello. Is it okay?
No, sir. No. Go ahead, sir. Go ahead. Now, probably you are.
Okay.
Yes, yes, absolutely fine. Go ahead.
So the headphone was not working, I think. So anyway, so we have this three varieties of long-acting insulin: glargine, detimir, and degludec. And as I've told you, that all three are excellent basal insulin, but to some extent, as the detimir has got a duration of action not up to 24 hours, but slightly less. In many cases, we have to give two injection to cover the whole 24 hours. On the other hand, glargine is the wonderful basal insulin, which has a duration of action roughly around 24 hours. And most of the situation, you can give it once in a day. The best among the lot, though come with a very premium price, is the degludec, which has got a duration of action is 42 hours. Now let us have a look into the insulin analog mixtures on the glycemic profile in type 2 diabetes mellitus. Now you can see that this is basically a basal hyperglycemia, and these are basically the mealtime hyperglycemia. In a diabetic subject, you have a steady hyperglycemia as a basal level, and every time you eat, with breakfast, with lunch, with dinner, you have prandial hyperglycemia as well. Now, we use the mixed insulins. So the mixed insulin has got two different varieties of insulin, and with the objective that they will correct both the mealtime hyperglycemia and also the basal hyperglycemia. So when we give two premixed insulin, this will give a basal insulin and a prandial insulin. And here, if we give another injection or another shot before dinner, it will provide a basal insulin and one prandial insulin to cover the dinner. Now let us have a look at the varieties of premixed insulin available in our country. Now there are short-acting insulin and intermediate-acting insulin combination is available. They are quite cheap. So I have given you the brand name, and they are available in two different proportion. One is 30-70 and 50-50. We cannot actually adjust the dose of either of this component separately. Whenever we are increasing the dose, the proportionate short-acting and intermediate-acting insulin will go up. So these are the insulins which are basically a mixture of regular insulin and NPH insulin. As because of the fact they contain regular insulin or short-acting insulin, you have to inject them 30 minutes before the meal. So conventionally, we give this insulin before breakfast and before dinner. And we expect that they will have a duration of action roughly 12 to 14 hours because it contains NPH insulin. So quite naturally, giving NPH insulin before breakfast and another NPH insulin before dinner will cover the whole 24 hour as the basal insulin supplementation. And the two short-acting insulin will cover the breakfast and the dinner. So the uh, lunch is basically remains uncovered, and therefore sometimes you have to give something at the level of the lunch. It may be a small tablets or it may be another short-acting insulin. Now we have combination of rapid-acting insulin and intermediate-acting insulin also, and this also available in the different uh, fixed proportion. So we have 25-75 and we have 50-50 proportion rapid acting and intermediate acting insulin, and we also have the aspart as a rapid acting analog insulin, and uh, then intermediate acting insulin combination also in two different proportion, 30-70 and 50-50. So these are the premixed insulin analogs, and therefore you will get the advantage of the rapid acting insulin over the above the short acting insulin. So which I have discussed already. Again, this premixed analog contains the NPH insulin, NPH aspart or NPH lispro, and these have got a duration of action almost same like other NPH insulin, and therefore you need to inject twice in a day to cover the whole 24 hours. The third premixed solution we call co-formulation, which is basically combination of rapid-acting insulin as part with that of the long-acting insulin, that is degludec, and this combination, aspart and insulin degludec, is also a very good combination therapy, which we can give once in a day or twice in a day. But as because they contain degludec, even if you give it once in a day, it will give a basal insulin supply for the whole 24 hours. And you, with aspart, you can cover 1 mealtime insulin or the bolus insulin. So usually we start this combination therapy before the main meal. So if the main meal is breakfast, then you give this insulin before breakfast. If the main meal is dinner, then you give this insulin before dinner, because that will cover this mealtime insulin, and the degludec will cover the whole 24 hour. So this is another excellent variety of combination we have nowadays. Now let us have a look how this human insulin and analog insulin works. So this is basically the basal part, and with the mill there is an when you are giving two injection, premixed injection. This is basically a mealtime insulin, and this is another mealtime insulin. So we expect that this will cover the breakfast, this will cover the dinner, but usually, as I've told you, there is no any mealtime insulin at the time of the lunch, and therefore lunch remains unprotected, and therefore sometimes we have to do something for the lunch. So this is about premixed human insulin. But when we give a premixed analog insulin, it is smarter than the premixed human insulin. So you can see that the peak is higher compared to the premixed premixed human insulin, and you can see that there is a rapid drop in the action, and therefore the possibility of hypoglycemia would be much less, especially possibility of hypoglycemia after dinner will be much less. So we can get a better control, number one, and number two, less possibility of hypoglycemia with this premixed analog insulin compared to premixed human insulin. So which kind of insulin you should start first? As because you have seen that we have basically three varieties of insulin. One, we have regular insulin. Two, we have premixed insulin. And three, we have basal insulin. Usually we don't treat patient with the regular insulin from at the beginning, because if you give regular, you have to give 3 shots, and also the fasting will remain uncovered. So therefore, we have to consider the 2 varieties. One, whether we'll give a basal insulin, or we can give the premixed insulin, or basal plus or basal bolus insulin. So what we will give? So conventionally and customarily, we actually start with basal insulin. So at initiation, we start the basal insulin. And after attaining the good fasting plasma glucose, if the patient have high postprandial plasma glucose, then we shift the patient to either basal plus or basal bolus or premixed insulin. So this actually we do it at the intensification. So to tell you very clearly that whenever you want to initiate the insulin therapy, it is always better that you start with the basal insulin. It is easier, the regimes will be easy to follow on part of the patient, and it is also easy on part of you and also on part of the patient to titrate the insulin dose. So barriers to insulin therapy in type 2 diabetes mellitus are many. So you can see sometimes we have limited resources for the management of diabetes. There is non-specialist setting. Patients are less educated. They may have poor adherence. So there is a delay in initiation of basal insulin. Sometimes there is limited accessibility of the basal insulin option, insufficient insulin dose titration, low treatment persistence. So there are a lot of challenges. But the most important challenge, I believe, is the mindset of the treating physician. So if the patient deserves insulin therapy, don't deny them, because insulin is the most effective way by which we can manage our type 2 diabetic subjects. And also, I would like to share with you that the basal insulin is a very, very safe method of starting insulin therapy. I feel it is safer than starting a sulfonylurea, though most of the physicians are very comfortable to start with sulfonylurea, but many of them are uncomfortable to start with the insulin therapy. But let me tell you that the starting basal insulin is much safer than starting the sulfonylurea treatment. So in the physician's mind is basically, there are a lot of issues. One, the patient resistance. And if there is a patient resistance, then there is a possibility that I may lose the patient. And they feel that insulin therapy requires intensive monitoring during the initial phase and during the titration phase, which is beyond the scope of the physician's busy practice, and possibility of hypoglycemia, which is always an important fear in the mind of the physician, also in the mind of the patient. Then the resources and the education, who will educate the insulin injection technique, who will educate the titration technique, who will actually give a demo to the patient, and how to manage hypoglycemia. So these are the all practical issues, and this is important, and the education is most important issue in the management of diabetes as a whole, also when you are giving an insulin therapy. More educated the patient, you will get more better, you'll get better outcome as far as the glucose control, as far as the control of complication is concerned. The insulin therapy often actually are often actually associated with weight gain, though the newer insulins are associated with less weight gain compared to the older versions, but still a weight gain is an important apprehension in the mind of the treating physician. So let me tell you that there are a lot of barriers in the mind of the physician, but many of them are actually not much important, and therefore what we need is to change our mindset. We need to understand that the insulin is a very effective method by which we can achieve a good glycemic control, and second, that the insulin therapy, especially the basal insulin therapy, is quite safe, as because we have very good varieties of basal insulin available at our disposal. So the brief consultation limit the patient education on safe and effective use of insulin. So either you have to increase your consultation time, or you have to appoint a diabetes educator who will discuss about the insulin therapy, who will show or give demo of the insulin injection technique, and will discuss with the patient regarding hypoglycemia and what to do about hypoglycemia. And lastly, if the patient is quite intelligent, then we can discuss about the titration algorithm, and we can empower the patient to take control of his diabetes and the glycemic control. And then we have the shortage of diabetes educator, as you know that this year that the World Diabetes Day had a theme of the nurses are important in our diabetes management. In our country, we don't have diabetic nurses. Actually, we have diabetes educators. They are almost similar compared to our Western counterpart, the diabetic nurses. So here we have diabetes educators, almost same. And I believe that they have immense role as far as the diabetes management is concerned. Very, very importantly, as far as the insulin treatment and giving demonstration for the insulin techniques, and also the discussing about hypoglycemia and titration algorithm. Unavailability of insulin, especially in the rural region, may be an important barrier. And very importantly, we have very few endocrinologists to meet the needs of the growing population of diabetes. But I believe that the diabetes should be actually treated by the physician, because it is not possible for the endocrinologist to treat the diabetic subjects in our country, which we have roughly around 77 million type 2 diabetic subjects in our country. So the limited number of endocrinologists will not give service to all these individuals, but the physicians must treat the diabetes, and they must learn the insulin therapy, because they will not be able to achieve a good control in many patients unless and until they switch the patient to the insulin therapy at the time of need. So let us have a look to the insulin regimes. As I have discussed that we should start with the basal insulin, but we'll discuss different insulin regimes, and then we have to look into which regime is most suitable in a particular patient. Now, there are different regimes we use. One is once daily, twice daily, intermittent acting, or long-acting insulin. So if we give intermittent acting insulin or NPH insulin, to give twice in a day. Most of the long-acting insulin requires once in a day therapy. So if you talk about the glargine or degludec, I'll give only once in a day therapy. But if the patient cannot afford glargine or the degludec, which is much costlier than glargine, then you have to give twice in a day NPH insulin, which is much cheaper. The second option we have is basically premixed insulin, and usually we give it once or twice daily. I have not given thrice daily premixed insulin. I don't use it, though the option is there. you can up-titrate the premixed insulin from once daily to twice daily to thrice daily. But usually I prefer to give premixed insulin most of the situation twice daily. So you can give it, you can start with once daily, then up titrate it, intensify it with twice daily premixed insulin also. So this is the second regime. Then we have the basal bolus therapy. So you give one basal insulin and 3 bolus insulin. So before breakfast, before lunch, before dinner. So there are 4 shots, 1 basal insulin at bedtime, and 3 mealtime insulin before breakfast, before lunch, before dinner. The short-acting insulin or the ultra short-acting insulin or rapid-acting insulin. Mealtime rapid-acting insulin only regime is not practical, and usually we don't use the 3 times rapid-acting insulin therapy. So basically we have 3 basic regime. One is long-acting insulin preparation, either once daily or twice daily. Then we have premixed insulin. It should be given once daily or twice daily. And third, we have basal bolus therapy, which is usually 4 times in a day, 1 basal insulin and 3 short-acting insulin before breakfast, before lunch, before dinner. With this idea in our mind, let us have a look into this patient. This is SD, a 55-year-old male, diabetic for the last almost 9 to 10 years, hypertensive, well-educated bank manager, on treatment with oral anti-diabetic only, is on irregular on follow-up but claims medication compliant. Many patients claims that I am continuing the same medication for the last 3-4 years without looking into the glycemic control. Now this sometimes happens. We have to change the mindset of the patient that only just taking tablets will not solve the issue. You have to keep an eye on your blood glucose level, whether it is controlled or not. His diabetic state is not under control in spite increasing doses of OAD and including 3 OAD to his treatment regime. Fasting 167, BP 290 and H1C 9.4 is quite high. Now, as I've discussed with you, the physiological pattern of insulin secretion is the basal profile, and we have 3 mealtime profile: breakfast, lunch, and dinner. So if we want to treat the patient only with a short-acting insulin before meals, we have to give 3 shots before breakfast, before lunch, before dinner. I usually don't treat patient in this way because the majority of the patient with type 2 diabetes has got a high fasting sugar. So we have to give a basal insulin to manage the fasting plasma glucose. So giving 3 short-acting insulin before breakfast, before lunch, before dinner, and ignoring the fasting plasma glucose is not a practical solution in majority of the situation. Now we can give a bedtime basal insulin and daytime oral hypoglycemic agent. Is a very, very good kind, because just giving so giving basal insulin at bedtime and giving a daytime oral hypoglycemic is a very, very good approach as far as the management of diabetes is concerned, because I believe if you give bedtime basal insulin, in most of the situation you will be able to achieve a good glycemic control. In most of the situation, only in 10 to 20% cases possibly you require intensification of the insulin regime. So if the patient is on sulfonylurea or other oral agent, you can consider reducing the dose of sulfonylurea, but I actually just add the basal insulin. How much dose you should give? You can remember this important calculation, but it is not very important to remember. Just start with 10 units at bedtime. Check the fasting plasma glucose every 3-4 days or every week. And target the fasting plasma glucose between 90 to 120 and uptitrate the dose every 4 days or every 3 days or every 7 days till you achieve a fasting plasma glucose between 90 to 120. So the issue is that that in the most of the situation we achieve a good fasting plasma glucose targets, and once you achieve a good fasting plasma glucose, in most of the situation you will find that postprandial plasma glucose also controlled, and you don't have to intensify the insulin regime. So as I've told you, the fasting fast. So this patient has got a elevated fasting plasma glucose, and over and above, they have the breakfast, lunch, and dinner values. Now, if we give a basal insulin, it will reduce the the fasting plasma glucose. So, as because the basal insulin reduces the glucose concentration throughout the 24-hour, we expect a significant drop in the postprandial plasma glucose, also with the use of the basal insulin only. So hence, try to fix the fasting fast. That should be our approach as far as the insulin therapy is concerned. Now, how we can titrate the insulin dose? There are a lot of regimes available in the net. You can use any one. This is a very simple algorithm given to you. Start with 10 units daily and check if you're giving 10 units daily at bedtime. Check the morning glucose. If you're giving this insulin in the morning, you check the pre-dinner glucose. So this is the way we have to check. Now, once you have looked into the fasting plasma glucose value, and if you find the value is higher than your target, in most of the situation, our target is 90 to 120 or 90 to 130. And if it is more than the target, you gradually uptitrate the basal insulin dose. You can go 2 units every time, or you can look into the titration algorithm and you can titrate at a higher level with higher titration value, say 4 units, 6 units, or 8 units, depending on the primal blood glucose value. So what are the benefits of once daily basal insulin regime? It requires only 1 injection per day. It helps overcome resistance to starting multiple insulin injection. It is particularly useful when patient blood glucose is high overnight and in the morning, and useful for patient who require someone else to administer their insulin. You are giving once in a day, so the help will require only for once in a day, and may be associated with fewer side effects than other regimens. As I've told you, that the basal insulin is not associated with much hypoglycemia, and it appears to be very safe approach as far as treatment of hyperglycemia is concerned. So coming to this patient, a 42-year-old male, not diabetic, weakness, lethargy, weight loss, local physician advice for blood test 258, fasting, PP 413, and HbA1c 11.4. So this is the first time detected for the diabetes. What you should do. Second, if you look into into this patient, we have the 2 options. So we can give 2 shots of premixed insulin before breakfast and before dinner. So this is the way, because this patient has got a very high fasting and PP value, and in that case we have to start the twice daily premixed insulin, and that, or we can give a basal bolus insulin. So premixed insulin twice daily is more acceptable to the patient because basal bolus regime means you have to give 4 shots. So if we give 2 shots of premixed insulin before breakfast and before dinner, what will happen? You can see that if you give 2 shots, 1 shot will try to cover the breakfast. The second shot will try to cover the dinner, As I've discussed, the lunch will remain unprotected, but as the premixed insulin contains the basal insulin or NPH insulin, so they will effectively control the fasting hyperglycemia. The another option is to cover this pre-lunch. One, we can give 3 shots of premixed insulin before breakfast, before lunch, before dinner. As I've told you, this is I don't practice this one. Rather, I prefer to give premixed insulin twice in a day, before breakfast and before dinner. So this is a 49 years male admitted in the hospital in deeply comatose following the head injury from road traffic accident, 180 by 110, and he had a pink white strap, random plasma glucose 455, H1C 10.3. You can see this patient is very easy to diagnose. You can see the pink stripe all over the body, and it actually gives the diagnosis that is a Cushing syndrome. So this patient has got a Cushing syndrome, also had a road traffic accident, admitted in the hospital, and therefore what we will do in this particular situation, we have to give basal bolus regime. Coming to this patient, 55-year male, type 2 diabetes for the last 9.6 years, bank manager, 3 OIT, irregular follow-up, complaints medication compliant, diabetic state not under control with the 3 doses of OIT, including twice daily premixed insulin in his regime. So these are the situations where the patient was admitted in the hospital with severe hyperglycemia, a patient who was not controlled with twice daily premixed insulin. And if we look into the examination finding, we find there's a multiple problem with hypertension, background retinopathy, peripheral neuropathy, H1C 9.4, ACR 340, dyslipidemia LDL 110, creatine 1.6, left ventricular hypertrophy. So the patient has got multiple risk factors for cardiovascular disease, and the patient has got a lot of other comorbidities like obesity, hypertension, dyslipidemia, and renal disease. So we have to start with intensive regime. So these are the situations where the patient is hospitalized with severe hyperglycemia. Patient who is receiving twice daily premixed insulin still failed to respond to the twice daily premixed insulin regime. We have to start the intensive insulin regime. Now this is the start the insulin. Usually we start with low dose. As I've told you, 10 units is basically the starting dose. You can calculate the total insulin requirement in the 0.5 units per kg. So in a say 60 kg body weight, we will give the 30 units per day, and both of 30 units, 40 to 50% we give as a basal insulin. So in a 60 kg body weight, when we are planning to give say 30 units, so we have to give say 40% or 50%, say 12 or 15 units of basal insulin at bedtime, and rest of the 60% will give in a 3 divided dose. So that should be before breakfast, before lunch, before dinner. So you can see that this is basically you have given the basal insulin and glargine, so you cover the basal requirement, and then we have given 3 shots to cover the breakfast, cover the lunch, and to cover the dinner. How we can monitor? We have to check the blood glucose at least 4 times in a day until the dose is stabilized before meal and at bedtime. You have to monitor actually weekly. It is always better to monitor at 3 a.m. value so that it can actually tells us whether there is any nocturnal hypoglycemia or not, because giving a long-acting insulin can produce nocturnal hypoglycemia. We can adjust the dose every 3 days depending on the situation, or you can adjust the dose every 7 days till you find that there is a pattern developing. Adjust only 1 dose at a time. Look into the hypoglycemia first and correct the hypoglycemia, and then you look into the highest prandial glucose, and then you correct that highest point. The dose is corrected by 1 to 2 units every 3 to 7 days until the target is achieved. Fasting plasma glucose reflects the bedtime long-acting insulin dose, and pre-meal glucose reflect the previous mealtime insulin dose. So you can check fasting and also before breakfast, before lunch, before dinner. But sometimes you can do the fasting and after breakfast, after lunch, after dinner, and to adjust the prandial insulin dose. Now, if the patient has got a high fasting sugar, how you approach? Now, if the patient has got a high fasting sugar, it may be because of two reasons. One is Somogyi, another is Dawn phenomena. If there is a fasting high, it means the patient has high plasma, high fasting, high sugar throughout the night. And if it is a high sugar throughout the night, and the patient will land up into fasting hyperglycemia, in those cases, actually we have to increase the insulin dose. On the other hand, if we look into the Somogyi phenomenon, the Somogyi phenomenon indicates that the patient may have nocturnal hypoglycemia, and followed by there is a rebound rise in the blood glucose value because of the excess secretion of counter-regulatory hormone like glucagon, growth hormone, cortisol. So the approach is to reduce the dose of long-acting insulin because of this long-acting insulin, you had a nocturnal hypoglycemia, and that is associated with rebound hyperglycemia, and that is why the morning plasma glucose is high. So this is the Dawn phenomena. You can see that the morning blood glucose is high because at night the blood glucose level is on the higher side. So the patient didn't have any control in the nocturnal blood glucose level. It is almost to the level of the 200, and in the morning it has gone up further. But if you find that the daytime blood glucose level is quite perfect, so unless and until you check in the middle of the night, you will not be able to estimate whether it is a nocturnal hypoglycemia or it is a nocturnal hyperglycemia. That has the contribution as far as the fasting plasma glucose is concerned. So increasing the insulin dose is the answer to this patient because the fact this patient has got a high plasma glucose throughout the night and it further went up in the morning. So the key message is the physicians can face resistance to insulin from their patient due to some patient beliefs as well as new clinical realities of insulin treatment. Education, education, and education is the most important step as far as the diabetes management is concerned, more so when you are planning for insulin therapy. And the diabetes educators or diabetic nurses are the very, very dependable healthcare people with whom actually you can coordinate and you can give responsibility to educate the patient regarding the insulin therapy. We have to use a very simple insulin regime, and as I've told you, starting basal insulin is very simple, possible to start on OPD basis, and it is very simple on part of the patient, very simple on part of you as far as the titration of insulin is concerned. But when the patient is in the hospital and when the patient has got multiple problems, as I've shown in the patients of Cushing's disease, then possibly we have to give the basal bolus insulin, which is a very complicated regime, and titration of the basal bolus regime is also very, very complicated. But giving a basal insulin, up titration of the basal insulin is a very simple method, and anybody can do it, and the patient themselves can do it for them. And educating the patient is an important challenge in front of us, and the physicians